Diabetes is another high risk, and both for developing diabetes if OSA is untreated, and also patients with diabetes should be screened because there's a high likelihood they will have untreated sleep apnea, particularly the diabetics who have difficulty stabilizing. If patients have hypothyroidism, acromegaly, vocal cord paralysis, Down syndromes, or patients with neuromuscular diseases also are at risk and should be screened for sleep apnea. What's the definition of sleep apnea? Well, there are a couple of types of sleep apnea, central and obstructive. But the obstructive type, it refers to mostly the part of the airway that is unsupported by cartilage. So when a patient lays down, air normally flows unobstructed through the nose or nose and mouth and through the oral pharynx and the oral nasal pharynx and down into the trachea. Particularly for patients who have rhinitis, other problems, polyps in the nose, big tonsils, that upper airway restriction will cause increased resistance to the airflow, and with the negative pressure generated as one tries to take a breath, then the airway will tend to close. Obstructive sleep apnea is where the airway closes, a patient tries to breathe, and the harder they try, they suck it closed more until they reach a point they actually can get the airway open. The other type of apnea is central sleep apnea. And with central sleep apnea, this is usually associated with a patient not breathing, that their system doesn't even tell them. Not that it's obstructive, but they aren't even told to breathe. And they are usually patients who have some sort of neuromuscular disorder. They've had some central incidents like a stroke or a traumatic injury, or patients with heart failure. And these people just won't make the effort to breathe, in contrast to obstructive apnea, where the patient makes an effort, but the airway is occluded. When the airway is totally occluded, it's obstructive sleep apnea. When it's partially occluded, they sometimes will work hard and get some air in and have hypopneas, or if it's partially occluded, oftentimes snoring is the symptom that you see. So there is a mix of patients with apnea, and approximately 80–90% of the patients who have apnea will have the obstructive type of apnea. Typically they'll have daytime sleepiness, where the people with the central apnea won't. So, how do we diagnose and treat sleep apnea? When patients complain of fatigue, unrefreshing sleep, when they have witness apneas, when they have hypertension, these are folks that we would want to send to be diagnosed. Additionally, there are patients who have a greater than a 17-inch neck for males or 16 inches for females are at risk and should be at least screened. Patients with small jaws, whether or not it's that the upper part of the maxilla is short, so sideways these people look like they have a big nose, but instead of a big nose, what they really have is that this portion of the face is back, which makes the nose proportionately bigger. Other patients are normal on the top part, but the lower jaw is short. And sometimes with men with beards or mustaches, you have to look kind of close to recognize that. So once we have people that we recognize are at risk, then we want to screen them for apnea. One method is to use an Epworth Sleepiness Scale. And this scale refers to people falling asleep and their tendency to fall asleep. So they rate themselves on a scale and say, how long would it take me to fall asleep if I were reading a book or sitting at a time. In these questions, it refers to driving a car or riding in a car. So if the patients don't drive cars or go in cars much, then this loses some of its validity. The Epworth Sleepiness Scale is a good measure for screening, but it's not very specific for why they're sleepy. And oftentimes, part of the sleepiness, even in those with obstructive sleep apnea, is associated with what we call self-sleep restriction. And that's that when they need to get more done, they simply sleep less. And so they aren't getting 8 hours of sleep at night and they're tired. The Berlin questionnaire is another option. It's 10 questions. It's focused purely at identifying obstructive sleep apnea. And it's easy to score, not too hard to use. Actually, I think is available in a lot of places, and I know the Philips people can provide that. Another questionnaire is called Stop Bang, and this was developed by anesthesia folks to look at people who are at risk of untreated sleep apnea and therefore at high risk with intubation for surgery. There are 8 questions, and it is validated for pre-surgical or preoperative screening. The Epworth scale looks like this, a scale of 0 to 3. If you're sitting reading, what is the chance that I feel like I would doze off? 0 to 1 to 2 to 3. And there are some descriptions that make it easier for a patient to consistently assign a number. The Berlin questionnaire is relatively short, and this questionnaire, as I mentioned, is available, and it has an NCR, no carbon required, copy in the back, and when the patient circles the answers, they go on there outlined for easy scoring. So it's a really great tool. Again, Epworth was focused at sleepiness, and the Berlin is focused on OSA particularly. So it's a good questionnaire. The Stop Bang, on the other hand, is one that looks at snoring, S, T, tired, O, observed, stop breathing, and it has other symptoms like that. So some of those are objective symptoms, which is really a great thing, so that it has a lot of validity. And the patient is considered to have high risk if they have 3 or more items that they say yes to. The diagnosis of sleep apnea is done by physical exam, and that physical exam usually includes an examination of the airway to see how the opening is to the back of the throat, and some people use a Mallampati scale or rating during that. We ask questions about their sleep, about snoring, about their lifestyle, and it's diagnosed by having a polysomnogram or a sleep study where the patient's EEG is monitored to see when they sleep, what stages of sleep they're in, and also their heart rate, their oxygen levels, airflow, efforts to breathe, and all of that is done and scored then for the patients, and they can then score it, give them what was called an AHI, and the AHI is an apnea hypopnea index, and if it's greater than 5 and they have some symptoms, they're said to be positive for sleep apnea, and treatment should be considered. So, what are the treatments that are available, and what are the screening devices or the sleep studies that are available? Let's start with the diagnostic instruments. The patients can be studied by full polysomnography. They would be using the devices that are computer generated, typically done in a sleep center. There are portable devices. One of the Philips Jacobs devices is called PDX, and this can be used either in a remote facility, a sleep center, or it can be used in a home, and the patient can be studied right where they live. And then there are other more screening type devices. These would be devices that are simple and easy. One is called Are You Sleeping? It's very simple. The patient wears a cannula on their nose, and that cannula looks at airflow and pauses in airflow. So it doesn't know if they're sleeping or not. It's a very rough screener, but it's very inexpensive, and the only investment is in a small cannula, and then the patient takes that home, sleeps with it, brings it back to the practitioner, and they look at the number on there. And there's guides within that that tell them when that number is critical, so where it should be used as an idea that they need to go to a sleep center.